Hi everyone, I'm Ed Highland. Welcome back to the Big Ideas Theater at AARC. I'm here today with Tanya Zeiger, who is with Mayo Clinic out of Florida. Tanya, thank you so much for coming by.
Well, thank you for having me.
I want to talk a little bit about the emerging role of the respiratory therapist in pulmonary arterial hypertension. Give us some thoughts, if you will. First of all, the big picture.
The big picture is my main job is to herd cats. I do a little bit of everything. I started off kind of taking on the role as doing something a little extra to the regular respiratory therapy duties. And from there it blossomed into, well, what do I need to do for my patients? So my patients ended up needing a lot of paperwork, a lot of hand-holding, a lot of discussion about their side effects. And as time went on, we actually developed a lot of new therapies. So as the new therapies came on, new side effects came on, new ways to actually order the medications and things like that came on. So a lot of paperwork involved. But the real reason that I do it is my patients.
Well, it's all about the patients, of course, and your experience, you find yourself networking a lot in terms of just, I mean, obviously at a conference like the AARC Congress is a good opportunity, but it seems like it's a year-round job trying to keep up with what's happening with technology, but also sharing the experiences of other people.
Absolutely. We do a lot of networking, not just with industry, because with industry we have not just new medications, but new modes of medication delivery. New things coming up all the time, patients constantly asking, well, what about the implantable pump? What about pill form? What about this? So we actually have to stay really quickly abreast with all of that information. We also have a lot of ongoing discussion with local physicians, with other physicians throughout the country, with what they're doing and when they need a second set of eyes to look at a problem.
Well, let's talk a little bit more about the patient and how is the patient benefiting and how does it make the job of the respiratory therapist better, more involved, and more caring?
Essentially, the patient benefits from someone caring, someone listening. I tell people all the time that it's not necessarily about your degree or your education, it's about you caring and wanting to find the answers. So I think respiratory therapy fits into that mold very, very well. We are people that always have worked with whatever was handed to us and worked within whatever scope we were given. So I think along that line, we tend to create our own path, create our own path along that road. Our patients depend heavily on me to maybe not know all the answers, but know where to find the answers. And I deal routinely with other divisions and other sections within not just our clinic and hospital, but other clinics and hospitals throughout the U.S. to find them the answers that they need.
What kind of things can you share about the educational needs? What has benefited you the most in terms of trying to gather the additional knowledge that you need to be good at what you do?
Well, the Pulmonary Hypertension Association puts on conferences. Every other year is an international conference, and the opposite year is a resource network conference. I actually attend and speak at both. I've actually managed for about the last 10 to 12 years to either speak and or be on the committees to put these things together. It is very interesting because as we developed our role within pulmonary hypertension, it's become more and more frequent that they actually were offering AARC CEUs and educational credits, whereas previously a lot of it came across as nursing credits that were rolled into AARC credits. So it's really blossomed into a welcoming role for the PHA to welcome in the respiratory therapy community.
Can you give us some thoughts about sort of like the state of the art? In other words, what's at the top of your list right now in terms of care and the information that you're receiving that may be kind of new? Because you've been doing this for a couple of years, and so and obviously that has changed over time. So what's the latest and greatest that we need to know?
So interestingly, when I started this journey, there was one drug and hospice. That one drug is still the main drug that we use. Unfortunately, it has a 3-minute half-life, so that makes me a key player in the patient's everything. when they go on trips, when they plan family outings. All of this becomes very integral to my life because of the fact that the patient needs to have backup plans. So with that being said, the newest, latest, and greatest, what has been FDA approved is oral therapy that is along the same pathway, which is prostacyclin pathways. It does have some challenges as far as being able to be tolerated with that particular route. It has some GI effects that patients have a hard time tolerating. So again, a little more hand-holding, a little more, how do I combat these issues? In some cases, I actually talk to them more than the patients who have implanted lines in their chest. The next thing coming that we're waiting for the FDA to put together is actually an implantable pump. And that our patients are chomping at the bit for. The reason being is it will actually be an implanted pump that will deliver their medication subcutaneously, and the patient will no longer have an open line in their chest. So they will actually be able to get out and go into the pool, they'll be able to go into the ocean, they'll be able to go tubing, they'll be able to enjoy all of the water activities that their friends and families are able to do right now, and they can't do because they have a choice of to live or enjoy those activities.
That lifestyle change, that would, just the patient attitude, the morale, that's part of the healing, caring process in itself.
Exactly. We have a slogan that it's okay to have a pity party, but at the end of the day, you're going to pull up your big girl pants and move on. And that actually came from a patient about 10 years ago who had a meltdown one day in a drive-through of a pharmacy, and she just melted down, and she called me and was just having a fit, and I said, okay, are we done? I've got the pharmacy on the other line, they've got your medication, it's all good, we've got this handled. Now can we pull up our big girl pants? And she said, yep, time to pull up our big girl pants and move on. So those are the moments. I've had patients tell me that it's not, everyone dies. Everyone knows that the eventual end is going to come. It's a matter of can we make it worth the ride? And that's my intent, is to give people the best quality of life as well as quantity of life.
Is this kind of a day-to-day thing for you in terms of the things you've just been describing? It sounds like you have a full day. In other words, you go in but you don't know which patient may call you because they're having that meltdown.
Exactly the case. And it's a 24/7 job. I get phone calls at 10 o'clock at night saying that their line came out, what do I do? I get calls at 7 o'clock in the morning saying, oh my gosh, I'm here at the lab and they don't have anything, what am I supposed to do with this? Or as in the call Friday when I was driving over here, we got a phone call saying I'm totally out of medication and they won't deliver, you need to call the pharmacy. And these are things that happen. And unfortunately, these are life and death drugs. These aren't something like a baby aspirin that they can just run to the pharmacy and get over the counter.
Well, Tanya Zeiger, thank you so much for coming by and sharing some thoughts with us. And it's an entire world that respiratory therapists are embracing and learning about caring for these patients.
Absolutely, and it's the best, it's the most rewarding part of the career that I could imagine to have stumbled into.
And that's the perfect message for us to say goodbye. Thank you so much for joining us.
Thank you.
This is the Big Ideas Theater at AARC. I'm Ed Hyland.